Good morning. How's everybody? All right. So I didn't get to do this yesterday. EMS, paramedics, EMTs. All right. Emergency department nurses. I am actually absolutely coming after y'all during this talk. So hang on. And physicians, floor nurses, ICU nurses. Fantastic. Fantastic. Peds hospital people. Zero. Couple. Two. No, you sort of raised your hand there. I'm going to ask you a question now. Good. All right. Well, good morning. Thank you again for having me back. I really appreciate it. This is important. It's important. I said it yesterday. If you have a healthy 1-year-old, the number one thing that's going to take them from you until they're age 44 is an injury. Between 1 and 14, if you add up all the causes of death, trauma's half, everything else is half. It's the most important public health issue facing pediatric patients in Mississippi, in Arkansas, in the United States, worldwide. As we make great strides with HIV, AIDS, and diarrheal disease worldwide, trauma is going to end up being the number one killer of children worldwide. So it's important. It's important. And that's really the question is, are we doing our best? Are we doing the things that are evidence-based to try to improve outcome when we encounter them? This is Arkansas-specific data, and this is Arkansas metric against the rest of the country. And we suffer a little bit. We have a little bit of higher teen suicide rate in Arkansas than the rest of the country. We're addressing that. But our unintentional injury, that first bar, you may not be able to see the axis there, but the first bar shows that our unintentional injury death rate is almost twice that of the rest of the country. When I started in Arkansas with the system in 2009, if a child that was in a car crash, their chances of dying were 3 times the national average dying in a car wreck. And I told you a little bit about why. We'll cover some more of that today, but I'll break it down. And again, I shared this story yesterday. I got to Children's Hospital and they said, "We don't need you. We're doing fine." And it actually was true. The Children's Hospital, the things that we did in the tertiary care center ended up making very little difference in the overall mortality of pediatric patients. Where it really mattered is where you work, in the pre-hospital arena, in the community hospitals, in the level 3s and the level 4s, and in the transfer process. That's actually where our morbidity and our mortality was occurring, or in our opportunities to salvage and save were occurring. And it's not a Mississippi issue or an Arkansas issue. This is a national issue. Most medics don't get to intubate an infant very frequently. Busy urban areas, you intubate about 1.5 times a year. So let me tell you something. It works the other way around. My hospital lives in sort of a rough neighborhood, and so every once in a while, an adult will just stumble into the Children's Hospital. You're talking about chaos. It is chaotic. And I go down, and at this point, I did adult trauma for a long time, but at this point, some 70-year-old comes in to my Children's Hospital. I'm scared. I don't mind saying it. I'm a little scared of them. I understand how it works in reverse. So we don't get a lot of opportunity to practice. We're out of our comfort zone. We're out of our skill set a little bit, and so things don't necessarily go as well. In our state, though, when we did our preventable mortality, these were the things that were killing kids. These were the opportunities that we had to salvage a kid or save a kid, and they're not the fancy things done at the Children's Hospital. They really were, did you put an airway in when an airway was necessary? Did you put a proper airway in? Did you decompress a chest when it was time to decompress a chest? Did you get IV access and give fluid if it was needed? Did you give too much fluid if it wasn't needed? Those were the causes of our preventable mortality in pediatric patients 150 miles north of here. Probably not much different than right here. Those were our causes. So you have to have a triage system that speaks specifically to children. There should be different activation criteria in your pre-hospital arena and in your hospital arena for an activation of a pediatric patient based on differences in physiology. And we're going to talk about all of that. Getting them to getting the ones that really need it to a pediatric trauma center is important. Traumatic brain injury is the #1 cause of death in pediatric patients, and 3 things have been shown to improve outcome. Just 3. Don't let them be hypoxic, don't let them be hypotensive, and treatment at a pediatric trauma center. Those are the 3 things. Those are the things we can do to improve outcome in a pediatric patient. This is the way they must look to you. That's the same way the 80-year-old looks to me. All right? That's my daughter, and that is the way she looked for about the first, between about 5 and 20, she looked that way. It's gotten better. It's gotten better. For those of you that had girls, it gets better. They turn into humans about 21. The boys don't do that. Pre-hospital. So as I think about how to maybe change my activation criteria, my sense of priority, these are the things that matter. These are the things that matter. The pediatric patient, I'm going to show you some slides about this later. The pediatric patient that is hypotensive, even mildly hypotensive, is way down the power curve. That is in trouble. You're in trouble if you get a pediatric patient who is hypotensive. Now, quick, what's hypotension? I got a 2-year-old coming in, lights and sirens. Come on, what's normal blood pressure supposed to be? I don't know. I don't know. I work in a pediatric trauma center. I see 1,600, I admit 1,600 pediatric trauma patients a year. I don't know. And when the lights and sirens are going off and everybody's looking at me, I don't know. We write it on a poster, and it sits in our wall in our trauma bay, what normal vital signs are. All right? That's what we do in the children's hospital. That's surely what you should do in your hospital where you don't see that many peds patients and you don't see them sick very frequently. Respiratory compromise, tachycardia, or tachypnea is a common compensatory mechanism for shock and a very important sign. Impaired mental status. Now, this one's a little misleading. I will tell you that it's not uncommon at all. You take a kid from mom and you strap them down, you put them in the back of the ambulance, so they scream and scream, and then what do? They get quiet and they get a little regressive. And that's normal, but you've got to activate on that. And so I spent the early part of my career going, God, I mean, the kid's just, and that's just a kid. That's just a kid. And they're not obtunded, they're not declining. But you can't know that in the pre-hospital arena, and you should activate on it, and we should activate in the hospital on it, and we're going to over-triage. Big deal. That's what we're supposed to do. That's what we're supposed to do. So those 3 things are really important. And if you want to think about it sort of pictorially, the assessment triangle developed by a guy named Bob Wiki really does work. If you have evidence that they're in shock and you can provide that to the hospital and your call in, I believe they're in shock because they have poor capillary refill, their heart rate is high, they're tachypnic, their blood pressures are low. I believe they are in shock. Then that is the highest level activation. They're having respiratory distress. They're breathing too fast, too slow, it's labored, it's uneven. That's respiratory distress. We're going to activate on that. Their mental status is declined, be it from a regressive behavior or a head injury, which is the most common reason that we're going to activate on that. All right? So that assessment triangle is a great way to think about it. It's a great way to think about it. If any of those are deranged, we're going to treat them at a high acuity. So what do I do? Now, I work in a level 3. I work in a level 4. I don't see that many kids. I sure don't see that many that are really sick. What do I do now? Well, it is good to go to the classes. I think the classes help. I think PALS help us with some baseline stuff. I think you'll get lectures like this. All those things help. What I think helps the most is consistency, checklists, and some tools. So I got a 2-year-old. My friends, the medics, called in. 2-year-old struck by a car. They believe he looks bad. Doc, I think he's in shock. I think he's in shock, and he's got a declining mental status. All right? Again, I'll put you on. What's a normal blood pressure? What's a normal blood pressure for this 2-year-old? I don't know. I think he's going to need to be intubated. What size ET tube? What size ET tube do we use for a 2-year-old? What size ET tube do you use for a 2-year-old? Anybody? You know what my answer to that is? Whatever that Broslow tape tells me. I don't know. I don't know. I'm telling you. But we use the Broslow tape, 1,600 trauma admissions a year, about 4,000 trauma evaluations in the emergency department. We use the Broslow every single time. You should not make this mistake. And it'll tell you. It'll tell you what tube you use. It'll tell you what blood pressure is. It'll tell you what the dose of etomidate is. It'll tell you all that. It should be used in the pre-hospital arena. And Broslow's a certain brand. You can make up your own. I saw a place the other day that had a Craftsman, tool cart, and they color-coded it. Perfectly fine. But during the code of a 2-year-old that you don't see a lot of those is not the time to try to guess. Use the Broslow. Use it and get it right. Use checklists for those things. Drill on this. Bring a 2-year-old into your trauma bay. Bring a dummy into your trauma bay and run through this activation and run through these things. And do we have the equipment? Do we have the processes in place? Do we have the people? Can we summon them if we need to? And then the biggest thing is phone a friend. Phone a friend. I am a click on a mouse away from your trauma bay. If you've got a Tandberg machine, if you've got a telemedicine machine, I am a click on a phone away from being in your trauma bay and helping you with the resuscitation. I'm positive that the Children's Hospital in Jackson's, the one in Mobile, all of those will do exactly the same. Get some help. Get some help with them. It really does matter. I love this picture. I love this picture. This picture is very meaningful to me. It is my about 31-year-old wife who was pregnant with our second son, our then 1-year-old son, and my 83-year-old grandmother. All right. What are the priorities of the trauma resuscitation for all 3 of those people? Exactly the same. Exactly the same. She's just a pregnant adult. He's just a little adult. She's just an old adult. They're all the same. It is control of active bleeding, airway, breathing, circulation. It is the same. And if you violate that, you will make a mistake. On any one of those 3 patients, if you violate that, you will make a mistake. But every one of those patients have unique anatomy and physiology that you got to know if you're going to do a good job. You know that if that pregnant woman comes in and she's hypotensive, you need to roll her on her side because her gravid uterus is sitting on her vena cava. You know that if you overextend that 83-year-old's neck with your intubation, that you're going to cause a problem. You should know that if you push the ET tube down, you put a 4.0 ET tube down in that 1-year-old, and you push it down to 20, that he's going to be right mainstem intubated. You've got to understand the subtleties of the anatomy and physiology to make their care different. But the priorities are the same. It's actually not those differences where we get in trouble. It's not the fancy things that we do for peds. It's not putting the ET tube in. It's not decompressing the chest when you knew that was the right thing to do. This girl sneaks out of school. I'm in Houston, Texas. This girl sneaks out of school with her friends, finds a gun in somebody's house. Entrance is just to the right of the sternum. Bullets in her left scapula. It's gone across her mediastinum, through her pulmonary hilum. She is dying. She's hypotensive. She's dying. What does she need? What is her priority of management? Airway. Second, decompression of her chest. That's how you save her life. That's how you save her life. Doesn't matter if she's a pediatric patient. This is a patient we'd operated on and had an exuberant fluid resuscitation. And his belly's big, and he's not breathing well. He's not making urine. He's hypotensive. You could bounce a quarter off his belly. What does he need? A decompressive laparotomy. He's got compartment syndrome. Absolutely no different between those two. It's pulling the trigger that matters. This kid crashes on an ATV, got active bleeding from a leg that's dysvascular. What does he need in the field? A tourniquet. Direct pressure. C, A, B, C. If you make a mistake with that because he's a kid, if you forget those things, if you don't do them because there's something special about being a kid, he dies. He dies. He doesn't have a shot. He doesn't have a shot. So let's go through it, let's go through those, that CABC then. The first thing is, you get a ring down from EMS or you get a call to a scene, and what do you expect? The 2-year-old's been struck by a car. I got struck by a car. Where are my injuries? They're here, right? Their femur, their pelvis, maybe chest. Those are the anticipated injuries in an adult struck by a car. What's the anticipated injury of the 2-year-old struck by a car? Head, chest, and then the transfer of energy. I don't know how much the damn car weighed, but it weighed a lot. And it hit me, and all the force is transmitted here, right? And it's pretty focal. You hit the 2-year-old, this big, and the whole force is transmitted everywhere. So the incidence of multiple injuries, much higher in the pediatric patient, because the same force has been applied, but it's not focal, it's transmitted everywhere. So I anticipate more, I'm worried about more. Head is probably going to be my most common. So already I'm starting to think about how I'm going to resuscitate, what my likely injuries are, what equipment I need. I'm going to need to intubate this kid. The adult, unlikely. Kid, probably. How am I going to get fluids in? Are they going to lose heat quickly? Absolutely. All right, so the first is airway. Airway. Most common reason that kids arrest is loss of airway. If in doubt, provide an airway. Provide an airway. Do you have a common resuscitation cocktail for pediatric patients? If not, you should. Do you have a rescue airway for the pediatric patient when you can't intubate? If not, you should. Are you going to be able to intubate with a Mac blade? No way. In the young kid, do I have a small Miller? A Miller 0 or 1 or a Wist nipple? That's what I need to intubate with. What size tube? Come on. Whatever the Broslow says. That's right. That's the answer. Whatever the Broslow says is what we're going to do. And one size above that and one size below that. So they're the things. ATLS told us to use uncuffed ET tubes because it caused problems in the pediatric patient. Let me give you a scenario. I don't intubate patients much. If I'm called on to intubate a patient, I'm going to put the Miller tube blade in and I'm going to lift. And if God himself touches me and I see the chords, angels sing, I look, I'm like, oh, and what am I going to put through those chords? Well, I'm going to probably put something too small because I don't want to come back here. Like I'm scared. I don't want to come back and put something else. So I put something that's a little small. Then I put it in and I start bagging. And it's uncuffed. What happens? Leak. So I'm not effectively ventilating. What's the number one injury in the pediatric patient? Head. What is the prime determinant of cerebral blood flow and swelling of the head? The entitled CO2. So now I've hurt the kids, I've made the head injury worse because I've driven up the entitled CO2 because I've put the wrong size ET tube in and I put an uncuffed tube in because that's what our service bought. That's all I got in the truck. That's all I've got in my Broslow bag there because we bought them 7 years ago and we haven't used them since. If I've used a cuffed tube, I put a little 1/4 cc of air in there, the leak stops. Peds Hospital will change it out later. I can ventilate now, I can oxygenate. I'm forgiven of my sins with that 1/4 cc of air. Throw away every uncuffed tube you've got and replace them with cuffed tubes. It matters. It really matters. I'm scared. I put that tube in. I put a 4.0 tube in. Again, angels sung as I saw it go through the cords. And I'm so scared. And I'm putting it deep because I don't want it to come out. How deep should an endotracheal tube be in a peds patient? 3 times the diameter of what you put in. If I put in a 4, it should be at 12 of the gums. If I put in a 5, it should be at 15. If you find that you've put and if you don't, you've got to run this check. It's got to be in your checklist. If I've put a 5 in and it's at 20, and I don't hear breath sounds on the left, should I decompress the left chest? Not until I've pulled back. And some of you are laughing. I see it daily. I see it daily. It's just a checklist. So 4 is at 18. It should be at 12. I'm going to pull back till I hear it. And if I get to 12 and I still don't hear breath sounds on the left side, fine. Decompress the chest. That's perfectly okay. But check on know those changes in physiology. What is my rescue airway? What am I going to do if I can't get this airway? I can't see it. It's really anterior. All I've got is a Mac blade. I can't find it. What's my rescue? Well, have one. Ours is an LMA. Our EMS, our local EMS crew, it's an iGel. They go down to 00. They're perfectly fine for infants. They'll get you out of a mess. Our cocktail for RSI is lidocaine, ketamine, and rocuronium. Use whatever you want, but be standard about it. That is not the time to begin to go, well, doesn't Dr. Avery like this and Maxson likes this? What are we supposed to use with Dr. such a... Pick the same cocktail, get them to agree on it, and use it the same every single time. All you then need is the weight of the patient to give the appropriate amount. Atropine is not really necessary for anybody over the age of about 6 months. You should have it on hand in case they become bradycardic, but over the age of 1, they really don't get that reflexive bradycardia. And so don't waste your time on that. It confuses the picture. You can't talk about airway management without thinking about cervical spine control. All right, the kid that comes in alive, what's the chance that they've got a cervical spine injury? Major injury, GCS3, broken arm, broken leg, scratches, blood everywhere. What's the chance they've got a cervical spine injury? It's about 0.1%. It is vanishingly low because kids break their neck in a different spot. They break it very high and they stop breathing. Most that have a broken neck, a significantly broken neck, die at the seam. They are apneic at the seam because they've lost their diaphragm and their chest muscles. So a kid who comes in awake, alert, screaming, you can almost roll the dice on that kid and say, that one doesn't have a neck injury. That one doesn't. What is the clearance for a pediatric C-spine? How is a pediatric C-spine cleared? Anybody? Clinically, it is not cleared by x-rays. It's not cleared by CT, so don't bother with it. If you think the kid needs spinal motion restriction, put them in spinal motion restriction and leave them there until you can clear them clinically. If you can't clear them clinically because you're transferring them, leave them in spinal motion restriction. All right, the chances of a decubitus ulcer is also vanishingly low in a pediatric patient in the first few hours. So don't worry with it. Most of the injuries are ligamentous. They're not bony. There's not a fracture in this kid's neck. It's not malaligned. It's a little wide between the occiput and C1, and the space between his trachea and his second vertebral body is wide. That kid's got a total internal decapitation. This kid is totally dissociated between his head and neck, and that x-ray is pretty normal. Pretty normal. As a matter of fact, it was called normal initially. So x-rays don't clear the pediatric cervical spine. CTs don't clear the pediatric cervical spine. It's cleared by checking the ligaments. They've either got to be awake, alert, and participatory in the exam, or you have to clear it with an MRI. So there's no reason to scan a 2-year-old's thyroid and thymus, increase their risk of cancer later in life for a test that's not going to benefit them. It doesn't clear them. It just takes time, pisses them off, costs money, and doesn't achieve your objective. All right, this 2-year-old's been struck by a car. You've intubated, you've pulled your 4.0 ET tube back to 12. You still don't hear breath sounds on the left side. This kid's ashen, gray, tachypnic, blood pressure's down. So you don't hear breath sounds. What are you going to do? You're going to decompress this chest. I can't tell you how many times I've been on the phone and a practitioner says, I'm not putting a chest tube in. I've never put a chest tube in a kid. I've never put a chest tube in a kid. Is there any difference? Absolutely. Don't tell Dr. Avery back there. It's a whole lot easier to put a chest tube in a kid. We've all put chest tubes in the 25-year-old guy that's a muscle builder. Hell, I can barely get the thing in. I can barely push through all that muscle. This is a piece of cake. The Thal-Quick kits, a needle, a wire, a dilator, and a Thal-Quick, perfectly acceptable. All you have to do is get a straw in there. You're just decompressing air. We'll deal with the rest of it later. Don't let them die of tension physiology. Put the tube in, decompress the chest. We'll deal with it later. I'm not sure. I'm not sure about that X-ray. I go back and say, I don't know if that's a tension pneumonia. Well, of course it's a tension pneumonia, but I don't know. Put the chest tube in. We'll deal with it later. We just don't see that many people die of aberrant chest tube placements. We see a lot die when the chest is not decompressed in a timely manner. All right. Circulation. Oh, by the way, what size chest tube? Quick, 2-year-old. Whatever the Broslow said. Oh, they can be educated. It's good. It's good. It's good. No different in Arkansas. All right, circulation. I think, Doc, they've been gray like this since we picked them up. They've been grunting. They've been tachypnic. They've been tachycardic. They're a little hypotensive. I need to get access, and I need to give them fluid. First of all, how much fluid? I want to give a bolus. How much? 20 per kilo. Why 20 per kilo? Where'd that number come from? Circulating blood volume in a pediatric patient is about 80 cc's per kilo. So the total body volume is about 80 cc's per kilo. Assuming that a patient needs fluid, we're going to assume that they're 25% down the curve, and 25% of that 80 is 20. That's where that number came from. 20 cc's per kilo. All right, how much do they weigh? Oh my gosh, I don't know. Mom's not here. 2-year-old? How much does a 2-year-old weigh? Quick. The Broslow. All right, you're a little too good. All right, this one you actually probably need to commit to memory. 2 times the age plus 8. All right, 2-year-old. 2 times the age, 4 plus 8. A little math early in the morning, I know, but 12. All right, in Arkansas, if they've got biscuit poisoning, you can add a kilo. Rarely are we going to take a kilo away. It's mostly right. All right, it's mostly right. It's mostly about 12, 13 kilos. You won't be far off. What's a problem is it's easy to be double. It's easy to be 100% off in the pediatric patient, and that matters. That really does matter. You underdose the succinylcholine by 50%, and then the cords are shut and I can't intubate. You double the amount of resuscitation fluid, and their head injury gets twice as bad because I've done that. That matters. Use the Broslow, know this formula, double check those things against each other mentally before you start an intervention. And then access. Okay, ED nurses. Come on, raise your hand. This gets brought into you. Oh. No access. All right, tell me, you don't have to do it because I know we're in the South and we can't really admit to this, but the devil himself sits on your shoulder and says, I'll trade you a pissant 24 gauge IV for your soul. You'll take it. You'll take it. And you will struggle and you'll stick and there'll be 7 IV catheters hanging out of this poor baby. And at the end of it, what you got? A pissant 24 gauge IV, right? Can't do shit through that. I mean, you're not going to resuscitate well through that. So you will all do it. You will all sell your soul. Here's the thing. In my trauma bay, I'm standing at the foot of the bed. There's a clock on the wall up there. If they're not sick, I don't care. Take all the time you want. Put a pissant 24 gauge IV in. I don't really care. If they're sick, that clock starts. At 180 seconds, if you don't have 2 22 gauge IVs or better in the baby, what do you get? An IO. An IO. Do you know where your IO's in? Have you practiced with them? Have you gotten a drill with them recently? So that when that baby does come in, you're not scared to death like all of us would be? You need to do that. This is where the simulation really does help. It really does help to have the scavenger hunt in the ED for this equipment, this right size ET tube, the right size chest tube, the Broslow tape, the IO. It really does matter. Here is probably the most important difference between the pediatric patient physiologically and the adult. All right, I'm 54 years old, and I have lots of vices. I get hit by the car, my wife shoots me something, and then the latter is likely to happen at some point, and I start losing a little bit of blood. All right, my arteries are hard because of all my vices, and I lose a drop of blood, and my heart rate goes up a tick, and my blood pressure goes down a tick, almost in a linear fashion from the beginning. That 2-year-old, very, very different. They're injured, their adrenals squeeze, their medium-sized arteries squeeze down, and they maintain a blood pressure that's normal until there is nothing left to squeeze, to move through that system, and then they go like that. That happens at somewhere around 40% of the circulating blood volume, or about 40 to 50 cc's per kilo of blood loss. They fall off the curve, and they are very difficult to salvage at that point. That's why I said earlier, a hypotensive child is in bad trouble. The hypotensive 54-year-old, maybe 10-15% down the curve. That 2-year-old is 40% down the curve. So start your activation with them. Start your massive transfusion protocol with them. You've got to do things different with that child who is hypotensive. They are in trouble. Start your massive transfusion protocol. Does your hospital have one? Do they have one that's weight-based? What are you going to do if it's the 2-year-old? All right? So we divide ours into 3 easy components: less than 20, 20 to 40, and above 40. Above 40 kilos, physiologically, anatomically, blood volume, you're an adult. Our massive transfusion looks just like our adult. That's what we do up there. For our peds, you all can have the slides. We start plasma early for that group. We keep thawed plasma. If in your hospital you don't keep thawed plasma, then what you have to do is activate early and call for it early. Because what you're going to do is you're going to give the blood that's available. You're going to give a little O-negative blood, and it's going to take them 20 to 30 minutes to thaw that plasma. But what you don't want to do is wait till you've given so much blood, not give them the plasma that they're coagulopathic at this point, and then start giving it. So order the plasma early. Tranexamic acid, hot topic EMS, hot topic in adult trauma. Probably the data says this: it's got to be given early, got to be given within the first 3 hours, only effective for people who have hypotension from bleeding, only effective in that group. And then the subset analysis really says that there's 3 types of people. There's those that make a clot exuberantly, those that clot normally, and then those that make a clot and break it down. It's probably only in that 3rd group that tranexamic acid is really beneficial, and you can't know that in the pre-hospital arena. So it's reasonable to give it. If you can test, it's reasonable to give it after testing, and it does have some effect in the pediatric population. We've done some of that work, and that's what I do. I'm sorry about the shift in the slide. 10 milligrams per kilo as a bolus over 15 minutes, and then 10 milligrams per kilo and a liter of saline given over the next hour. So it's probably got some effect. It may have some effect in head injury. Its mechanism is not well understood. There'll be more on that later, but it's reasonable. It's a reasonable adjunct to your massive transfusion protocol. All right, back to this kid and disability. Most common thing that they're going to die of is the head injury. So you've got to be cognizant of that. Babies need a modified GCS. I can't ever remember what it is. We write it on a poster and put it on our wall. All right? And it's good to have that because it is nice to communicate with the receiving hospital. They came in with a 12. They're now a 10. You know, I'm thinking about intubating because of a decline. That makes sense to me. I can sort of get that. There are Brain Trauma Foundation guidelines for pediatric patients. Now you're thinking, I don't care. We don't have a neurosurgeon. This is not my problem. Actually, it totally is your problem. What percent of patients with head injury, I said this yesterday, what percent of patients with blood in the head need neurosurgical intervention? 10%. 90% do not. But a pediatric patient with a brain injury who has 1 episode of hypotension, 1 episode of hypoxia with SAS below 80 doubles their mortality. You affect their outcome, not the neurosurgeon at the pediatric hospital. You in the pre-hospital arena, you in the level 3 and level 4 hospital. So the Brain Trauma Foundation says that everybody ought to be able to do the first tiered response to a brain injury. Everybody ought to do this, and this ought to be a checklist. This is a checklist at my place. We do not walk out of the trauma bay without assuring that we've done all of these things. And I do this every day. You should have this checklist because you don't do this every day. Head of the bed should be elevated in reverse Trendelenburg. We don't flex it, we put it in reverse Trendelenburg. Get the head up. It increases drainage from the head. The head needs to be straight. I take residents in the ICU all the time, and we have people that have died, brain death, and I bring the residents in. We have a monitor in their head, and I touch their neck lightly, just enough to compress their jugular vein. And within about 15 seconds, their ICP starts going up. And I make the residents watch it, and I hold it for a second, and their ICP goes up, and I let it go, and their ICP comes down. Drainage from the head makes that much difference. Make sure their head's straight. Make sure their collar's not too tight. Make sure the head of their bed's up. All right? Those are the things you can do. 3% normal saline is very safe in the pediatric patient population. It restores intravascular volume, which is good for them. It's got an anti-inflammatory effect for head injury that's good for them. And it's given at 3 to 5 cc's per kilo in a push over about 10 minutes in our trauma bay. It should be really available almost in every emergency department, I believe. And then anticonvulsants, and we use Keppra. You can use whatever you want, but I think Keppra has the most benign side effects. It doesn't drop the blood pressure, doesn't let them get hypotensive. I want to go back and say the 3% normal saline versus mannitol. Mannitol is our go-to drug forever. The problem with mannitol works as a diuretic. So I don't know what you've been doing all day. You're out drinking beer, you're out in the hot sun, you're dehydrated. I give you mannitol, I pull fluid out of your system, I drop your blood pressure. So we don't give mannitol early in the trauma bay. We give something that restores intravascular volume and has the same effect on the brain, the 3% normal saline bolus. So 3% for me is my go-to in the trauma bay. I might give mannitol later in the emergency department. I mean in the ICU, as I'm sure I'm intravascularly filled and I want to get more water off the brain. So I personally don't think mannitol has a place in the emergency department or pre-hospital arena, except after you've done this and there's still impending herniation. Very rare incident. And we use Keppra for anticonvulsants. End-tidal CO2, I told you earlier about the intubation story, how much the end-tidal CO2 matters to cerebral blood flow. Should be kept relatively normal unless there is impending herniation. And I've said that a couple of times. One pupil is blown, one pupil is not blown. It's still reactive in their posturing. Very rare. Very rare. But it does happen. That's the only time you really should hyperventilate. Everybody else should be pretty normal. Temperature should be maintained at normal, not too cold, not too hot. But the biggest thing is don't let them get hypoxic. This is not the time to have the student intubate, the new medic intubate. This is the one that needs the most experienced person in the room. And then rapid transport. Those are the things that every one of us can do in any hospital in Mississippi, any hospital in Arkansas. And those things make more of a difference in outcome than what I do at the Children's Hospital. Suspected spinal cord injury. We're still on neurologic disability. There is really good data that says that if a person has a known deficit, I can't, the story earlier, I can't feel my feet, I can't move my arms and legs. Here are some caveats, I think, that are true for the pediatric patient, that are true for the adult patient, and they really don't differ for peds. Steroids have no place. Steroids have no place in the management of spinal cord injury, except with the approval of the final treating neurosurgeon. There are a few rare times where we'll use steroids, but that's a pretty nuanced decision. If you're going to err on the side of no steroids. If you have a spinal cord injury, there is some evidence that pushing your blood pressure up does help. And so we use norepinephrine for upper spine injuries. We use phenylephrine for lower spine injuries. And we start that in the emergency department. No different from adults or peds. Exposure. The kids lose my energy expenditure. I take in more calories than I expend energy, but my energy expenditure is about 25 to 30 kilocalories per kilo per day. That 2-year-old that I've given you as the example is about 100 kilocalories per kilo per day. So that kid's a furnace. That kid is really churning out the energy. And if you leave them uncovered, they dissipate heat quickly. And so don't leave it. The room really should be uncomfortably warm for you. You should use the bear hugger. You should use blankets. You should use the fluid warmer. You probably ought to invest, if you don't have it, in a Ranger warmer. And I don't have any stock in Ranger. It's the most simple thing to use for pediatric fluid because the level 1 is too big. It's just too big for some of the pediatric patients. Keep them warm. Keep them warm. We involve the family early. There's no, Versed is not as good as mom. It's really not. There's nothing to calm a baby and get an exam like a parent that will come in and help comfort. So I think they're incredibly valuable. I think, the patient can't tell you their meds, the patient can't tell you their allergies, the parents can. We get them involved early. We have a chaperone for them. The chaperone says, Dr. Maxson, can I bring the family in? And I get to decide sort of yes or no. But the answer is usually yes, I think this is the right time. Even when things are going terribly, I've had parents that don't really understand what we're doing, but they saw the effort that was put forth when I knew things were not going to go well, and that made all the difference for them. I've had a father, I looked up one day, I'd done a resuscitative thoracotomy, I'd opened this kid's chest in the ED, and as it usually does, she died, and I looked up and the father was there, and I was just horror struck. I thought, how could I have let that man see that? He came to me later and he said, I didn't understand everything that was going on, but he said, my wife, who was also in the car crash, I was able to call her and say, everything that could have been done was done. And so he left devastated, but peaceful about the resuscitation. So I'm a believer. Don't underdose them. It doesn't mask. Don't underdose their pain. They break their femur. It hurts. You put a chest tube in, it hurts. They've got a brain injury and you've intubated them. They are unsedated and it drives up their cerebral metabolic pressure and it drives up their ICP. Dose them properly. It does not mask their exam. It doesn't keep us from finding the belly injury or something like that. It's short acting. It's going to wear off. I don't care what the neurosurgeons all say. Don't give them anything so I can examine them. You can wait 5 minutes. It'll be gone in 5 minutes. We're going to treat their pain. So I don't worry about that. You should have protocols in your hospital. If you have general surgery, you should have protocols for the management of solid organ injury. Very, very rarely do we need to intervene. This is a physiologic difference between adults and peds. Again, I've got hard calcified arteries, not much reactivity. I train residents, so I have no sympathetic tone left. I mean, my adrenals are expended from training residents for 25 years. So I get a blush on my CT and my spleen. I'm going to keep bleeding, and Pete's going to have to take my spleen out. I'm going to keep bleeding. The 2-year-old, again, is going to clamp down, even with active extravasation on the CT, is going to clamp down, stop bleeding, make a clot, and this is going to be fine. We treat over 93% now of our solid organs injuries without operative intervention, and the time that we intervene is when we have to intervene for something else. The time to failure for solid organ injuries in our big study that we published called the Atomic Protocol was about 3 hours. And so those that make it to you after a couple of hours and that look okay after a few hours are going to be fine. They don't really need much intervention. So that's a physiologic difference. Every once in a while it's got to come out, and if it comes out, understand what the CDC recommendations are for prophylaxis and antibiotics after splenectomy. And I would say that our pendulum, and I show this picture because our pendulum is swung to where we don't take out many spleens, we don't intervene much, and so quite frankly, we pediatric surgeons have gotten not so good at intervening when it's actually necessary. Our biggest morbidity and mortality is intervening too slowly on this. So just as I'm sort of telling you, here are the things I want you to do in the community hospitals and EMS, I have these same conversations with my pediatric surgical colleagues about not waiting too long, intervening a little sooner when it's really necessary. Disability. So this baby is brought in. He just fell off the couch. He fell off the couch. His sister was trying to carry him and dropped him. Is that right? Seems unusual. We dropped our babies all the time, me and Amy did. They're retarded, but they're not. I mean, really, one of them's kind of stupid, but they're not dead. Of course not. Of course. First of all, that baby doesn't roll, so the injury is inconsistent with the developmental stage. The presentation is during the day. The mom's evasive about questions. It happened last night, but she didn't bring him in until today. I'm not profiling, but profiling is valuable in sometimes. It's a single woman doing her best, and there's a boyfriend in the scene. Those things are all signals for us, and we see this daily. Daily. All right. So you need a pathway. Let me tell you a story. We did this study in Austin, Texas. Austin, Texas is about 35% Hispanic, about 20% African American, about 5-6% other, and then the rest is Caucasian. We called the child assessment team. We called the Department of Human Services 100 times during the year, probably 400 times during the year. We called on low socioeconomic. We called on Hispanics. We called on African Americans, and they got adjudicated. And we did that based on the physician's perception of who was telling the truth and who wasn't telling the truth. We said, that's not okay. Every one of us bring our biases into that judgment, into that decision making. When we put a protocol in place that said, if you're under the age of 18 months and you've got a skeletal injury that's not from a motor vehicle crash, if you've got a frenular tear, if you've got a burn, if it's a special needs kid, you will get Child Protective Services to look at it, our social worker look at it, a trauma consult, because that's a patient found down. You will get a skeletal survey. You will get screening laboratory values for liver injuries and for abdominal injuries, and we'll get a chest x-ray. You will do those things. When we started doing those things, our number of adjudicated, our calls to Child Protective Services stayed the same, but the demographic of who we were calling and who finally got adjudicated as abusers looked like the demographic of Austin. It looked like that demographic. So what that said is that we were letting white affluent kids go home that were being abused. That's what we were doing. And that's not right. That's not right. It's not the right way to do that. And actually it makes my job a ton easier. It makes my job a ton easier to say to the one mom, no ma'am, I'm not calling them because you're Hispanic and low socioeconomic. No ma'am, I know your husband's a prominent lawyer in town. We call on everybody. If they have these injuries, we call them. Makes my life easy. Makes my life super easy. And I'll tell you that most of the children's hospitals will be happy to receive your patient that you're just not sure about. Just call, we'll take them. We'll take them. So have a pathway that you stick to for who you're going to assess and call them. Last thing I want to say is there are psychological consequences of injury. I have to tell you, for the first few months after my injury, I was teaching the retarded kid. I was teaching him to drive, and really, which is scary to begin with. But he would swerve a little bit, and I'd see a car coming, and I had a few little moments of flashback there. So we think about it in adults, we think about it in war, we think about it in these cataclysmic events. It's hard to imagine that this kid is at risk for PTSD, right? He looks pretty good. But the truth is that about 30% of our major trauma patients have signs and symptoms of acute stress disorder while in the hospital or shortly thereafter, and if not addressed, it becomes post-traumatic stress disorder, and that ends up being the worst morbidity that they take lifelong. The bones are going to heal, the spleen's going to heal, the PTSD will not heal if not treated. And so we're supposed to do something about that. We wrote about this, we've written about this a couple of times and published and published that. We've also looked at risk-taking alcohol and drug use in the pediatric patient population. So over the age of 12, it is important there's a validated tool, just like you use the audit tool for adults. There's a validated tool called CRAFT for the pediatric patients, and it's worth doing. I believe strongly that you might change my behavior after an injury with brief intervention. With intervention, you might. The data says that you probably are. I'm positive that if you can intervene on that 15-year-old who's already got risk-taking behavior, you can save them recidivism. You can save them from coming back in. I know that that's true. We've documented this and published it, so it's worth having a protocol for that. The best thing you can do is not have the injury in the first place. Your injury prevention efforts, you can't imagine how powerful your podium is in your community to do some of this work, to go do injury prevention work. It's very powerful. It makes a difference. Those kinds of things. Car seats, booster seats, they matter. Smoke detectors. Preventing these injuries is the best use of your time and dollar that you could possibly do. I'll show this one. I live in Arkansas, you live in Mississippi. We're not going to get gun control. We're not going to get gun control in our state. And no matter what you or I think about that, but the message that is successful, even in our state, is responsible gun ownership. With the right comes the responsibility. I have a responsibility if I have children in my home to be safe with my gun. I own a gun. We own guns. We hunt. My kids hunt with me. Proud of that. I have an absolute responsibility to be sure that that they're not misused. I have an absolute responsibility to do that. So that's our message that I think is successful even where we live. All right? And then try to keep them from drinking and driving. I appreciate very much being asked to come here. I've loved being here for a couple days. I appreciate you all being here and your what you do every single day. And I'll be happy to answer any questions. Thank you. Any questions? Yes, sir.
3% normal saline versus 9%.
Yeah, 3% normal saline versus 9%. The problem in the pediatric patient population, 3%, because the 9% or the 7.5%, if misdosed, has a big consequence to it. So in adults, doesn't matter that much. Pediatric patient population, it does matter. I know the higher the concentration, probably the more effective it is in the lower dose. But our kids don't have CHF, and the 3% is as effective, and its safety profile is just a little bit better than the 7.5% or 9%. So it's doable. We don't use it, and that's the reason we don't. We don't want somebody grabbing it thinking, if we grab the 3% thinking it's just saline and we give it as a saline drip, well, that's a problem, but it's not as big a problem as if it's 9%. That's why.
Is that just for head injuries?
Well, we use it so is it just for head injuries? We use it for head injuries. We use it in our burn patient population, and then we use it if we have an open abdomen for the next day or so to try to decrease swelling. So we use the hypertonic saline in those 3 ways. Good question.